Good morning, good afternoon, good evening, everybody. My name is Dieter Hafner, and I have the opportunity to introduce our IPNA webinar of the day. It's about an important topic. It's about pediatric UTI, the North American recommendations. The talk will be presented by Brian Becknell. I will introduce him in a short time. And today I have a co-chair. It's Eugen Chan from the Hong Kong Children's Hospital, and he's a colleague coming from the Professional Education Committee in IPNA. And this is really beautiful because today the two moderators and the presenter present, let's say, 3 continents, and we are spanning more than 13 hours of time gap. So it's 10 a.m. I understand in Columbus, Ohio. It's 4 p.m. in Hanover, Germany, and it's 11 p.m. in Hong Kong. So it's really international today, and I noticed that we already have 135 participants, no, 39, and it's still growing. So without further ado, I would be happy to introduce our speaker of the day. It's Brian Becknell. He's a very well-known pediatric nephrologist. He's working at the University Hospital in Columbus, Ohio, and his research is dedicated to the pathogenesis and the treatment of UTI, especially with respect to kidney malformations, to CACUT, and he's also dedicated to the pathomechanism and treatment of progression of kidney disease in patients with CACUT. So I think there would be no better colleague to explain to us the recent published recommendations from the North American Society on pediatric UTI. And Brian, it's your floor. We are listening to you. And
Thank you so much.
So I would just want to mention, I forgot, during the talk, you can already ask questions, and later on we have the questions and answers round, but feel free already asking questions during the talk so that we can immediately start after the Brian's talk. Sorry for interrupting, Brian. Now it's for you. Thank you.
Thank you, Dieter, and thank you, Eugene and Lucy, and to IPNA for organizing the webinar series and for the opportunity to speak today about UTIs. So I have no disclosures. For the next 35 minutes or so, my goals are to discuss the 2011 American Academy of Pediatrics guidelines for the diagnosis of UTI and its management in febrile infants and young children, and to review the literature along with other guidelines that have emerged over the last 9 years, and to ask if they stand the test of time, as well as to highlight ongoing knowledge gaps and research opportunities in this field. So today I'm going to focus mostly on UTI management in infants and young children, as this is the subject of the AAP guideline. And in this age group, which is generally defined as 2 to 24 months, and some guidelines state 2 to 36 months, the prevalence of UTI is high, around 5%. The incidence of UTI is roughly equal among males and females in the first year of life. Subsequently, UTI are more common in females. The most common presenting complaint is high fever without a source, and this reflects the higher rate of pyelonephritis in this age group, as you can see here in this recent excellent review from Chaltoulas and colleagues in Lancet. So as I review the AAP guideline, I'd like to make a couple of points from the beginning. These guidelines were developed specifically for children aged 2 to 24 months who are presenting with a first febrile UTI, who do not have any known neurologic or anatomic abnormality that would be associated with UTI susceptibility or recurrence or renal injury. So, I mean, many of us, all of us as nephrologists, care for children who have known obstructive uropathy, renal dysplasia with high-grade reflux, spinal dysraphism, polycystic kidney disease, lots of disorders that can be associated with complicated UTIs. And we may meet such children in the course of their evaluation for a first febrile UTI, but this guideline does not address their subsequent management. Accordingly, the panel that is responsible for devising and revising these guidelines is going to consist of general pediatricians, infectious disease specialists, epidemiologists, radiologists, a pediatric urologist, and a pediatric nephrologist. The AAP made 7 recommendations about diagnosis, treatment, and imaging related to UTIs. Some of this is going to be very simple. So with regard to recommendations for UTI diagnosis, the AAP begins with a guideline about patients who are ill appearing. And if they are sick appearing and as assessed by the clinician, a febrile infant should obtain urine for diagnostic studies in a definitive and direct way, directly from the bladder via suprapubic tap or catheterization for both urinalysis and urine culture prior to administering empiric antibiotics for presumed diagnosis of UTI. The diagnosis of UTI itself requires both a urinalysis with evidence of either pyuria or leukocyte esterase or bacteriuria or nitrites and a positive urine culture. The AAP defines this as greater than 50,000 colony forming units per ml of a single uropathogen. Now, the rationale for this type of diagnostic testing before antibiotics is straightforward. The administration of antibiotics with broad spectrum bacteriostatic or bactericidal activity would make it difficult or impossible to recover the causal microorganism, leading to no definitive UTI diagnosis. The rationale for suprapubic aspiration or catheterization as opposed to bag urine specimen lies in their differential specificity for UTI. With the bagged urine only 63% specific for UTI, if you consider the UTI prevalence of 5%, this means the positive culture based on a bagged urine would have a false positive rate around 88% of the time, which would be unacceptable. In contrast, the catheterization or suprapubic aspirate are 99% specific for UTI. With regard to the use of urinalysis and urine culture, the urinalysis allows the provider to use point-of-care data for clinical decision-making. The presence of pyuria specifically can help distinguish the possibility of UTI, whereas its absence could help in decision-making by identifying a potential for asymptomatic bacteriuria or a contaminated specimen. The urine culture, of course, is the final arbiter of UTI, with a negative result help reducing over prescription of antibiotics, and a positive result helping to tailor and sensitivities helping to tailor antibiotic choice. In contrast, if the infant is well appearing and febrile, the provider is counseled to assess the likelihood of UTI. And if low, observation is certainly an option. And if high, urine should be obtained for diagnostic testing. I always felt that this table was a little bit difficult to look at. But what the Academy is intending to provide here is a list of the individual risk factors for UTI in girls as well as in boys that are based on decision rules that were established in large series of infants that were presenting to the emergency department. The risk of UTI with no source of fevers on the basis of the clinician's assessment, that is history and physical exam, is around 5%. The likelihood is greater in girls than boys if they're over 1 year of age, but males have a 5 to 20 times greater likelihood of UTI if they are not circumcised and they are less than 1. And the presence of another clinically obvious source of infection reduces the likelihood of UTI by 50%. So the provider is counseled to make a decision based on their threshold of likelihood of UTI, whether it's less than 1% or less than 2%, and to weigh in the risk factors present in order to establish whether diagnostic testing is indicated. Recently, a clinical calculator has been developed and validated for estimating the probability of UTI in young febrile children in this age range. This was developed by Nader Sheikh and colleagues at the University of Pittsburgh Medical Center. They specifically developed this calculator to establish the probability of UTI based on the clinical risk factors, such as the ones on the previous slide, and then to update that probability based on the results of your analysis. They performed a nested case control study in over 2,000 children and compared the performance of that model to that of the AAP algorithm on the previous slide, and found that their model reduced testing by 8% and decreased the number of missed cases of UTI. I've shown the URL for the website. Here's an example of what the calculator looks like. So if we take the example then of a 9-month-old well-appearing Caucasian female with 1 day of fever up to 39% Celsius and no obvious source, who presents to her pediatrician's office, and you plug that into the calculator, it says that the probability of UTI is well over 2%, in this case 25%, and the clinician receives the message that the pretest probability of UTI for your patient is relatively high, greater than or equal to 2%, and many clinicians would order a urine sample in patients with this probability. I think calculators like this and ones like it are very powerful in the sense that it provides a generalizable and user-friendly platform. It might allow for a more uniform assessment of UTI risk. It may need to be tailored in a way geographically to better represent the patient population. But nonetheless, it's a very good idea. Now, if UTI is suspected in a patient who is febrile but in good clinical condition, there are two choices that the provider can make. One is to obtain urine directly from the bladder via catheterization or suprapubic aspirate and to send that for urinalysis and culture. Alternatively, and more often in the office setting, the two-step method is described, whereas where a bagged urine sample is obtained and sent for urinalysis. If there is positive for leukocyte esterase or nitrite, or if microscopy were to identify leukocytes or bacteria, then the urine would have to be obtained by catheterization or suprapubic aspirate for culture. Alternatively, if the urinalysis is negative for both leukocyte esterase and nitrite, then the provider would have the choice of monitoring the clinical course. I think that at face value, this two-step method seems appealing. It's less invasive, but if you strongly suspect a UTI in this child, as the example suggests, what to do in that situation. Many providers would want to send a urine culture despite a negative urinalysis, but then the lack of specificity for urine culture from the bag specimen presents a problem. And our local guidelines in Columbus recommend catheterize UA or urine culture when UTI is suspected. The AAP guidelines do not discuss clean catch. And some of my colleagues chuckle at the prospects of obtaining clean catch urine from young children in this age range. Nonetheless, the possibility of clean catch is suggested by other guidelines, and there are procedures that are described to rapidly and effectively obtain urine by clean catch method from children in this age range. There are some important caveats to mention with regard to urinalysis as a screening tool shown on this slide. For one, the sample of urine needs to be fresh, either analyzed within 1 hour or within 4 hours if refrigerated. The requirement for pyuria is well intended. It can aid in distinguishing asymptomatic bacteria or contaminating bacteria from a true UTI on the basis of the body's immune response, which should lead to phagocyte recruitment and leukocyte esterase or pyuria. However, the leukocyte esterase suffers from a lack of sensitivity, and it can be negative in at least 10% of febrile patients with positive urine cultures. Furthermore, certain bacteria do not elicit leukocyte esterase as readily despite causing UTI. Bacteria such as Enterococcus, Klebsiella, and Pseudomonas fall in this category. And leukocyte esterase can be absent in up to 11% of E. coli UTI. Now, some studies also have argued that the frequency of asymptomatic bacteriuria is actually much lower than previously appreciated and lower in certain circumstances than UTI. And this has been used as an argument against a reliance of pyuria on making a UTI diagnosis. And finally, the detection of nitrite, while highly specific for UTI, around 98%, depends on the type of bacterium present. It's not going to be present, for example, with gram-positive bacteria, UTI, and certain gram-negative. It also requires that the urine remain in the bladder for 4 hours, and it's thought the bladder cycles quite frequently in children in this age range, and that would be less likely. So these are caveats. And efforts have been made over the years to augment the performance of the urinalysis. This is an ongoing area of investigation. The enhanced urinalysis, which consists of enumeration of white blood cells and gram-negative rods on uncentrifuged urine, does have value and is used in certain instances, but requires a setup to do so. And there have been a number of investigations using about the detection of additional host-derived innate immune factors, such as those shown, and to determine if they may have utility in UTI diagnosis. And this is an area of research. There's also the matter of colony counts. Some laboratories report urine culture results in a range of 10 to 100,000 CFUs per ml, and this spans the 50,000 threshold that was defined by the AAP. And other recent studies have argued that a threshold of 10,000, a lower threshold, would identify appropriately those children with UTI who are presenting with both fever and pyuria. And the Italian Society of Pediatric Nephrology guidelines have lowered their threshold to define it as greater than 10,000 CFUs per ml in catheterized specimens in such instances. Now, with regard to the treatment of UTI, the AAP makes a statement about the choice of antibiotics en route that makes sense. A number of studies have demonstrated that oral and parenteral antibiotics are equally effective. Many providers would provide IV, intravenous, or parenteral therapy for infants up to 3 months of age, particularly if ill appearing. And the choice of antibiotics itself will be based on local antimicrobial sensitivity patterns, and of course adjusted as needed on the basis of antibiotic susceptibility as culture results become available. The AAP guidelines specify a duration of 7 to 14 days for antimicrobial therapy. NICE guidelines from the United Kingdom state 7 to 10 days. The Italian Society of Pediatric Nephrology states 10 days, unless the patient has urosepsis, in which case 14 days are recommended. Ongoing studies are needed to define the optimal duration of time for treatment of febrile UTI, but studies have demonstrated that it is a good idea to treat for at least 7 days. A shorter duration is likely insufficient. Whereas in cystitis, a type of UTI common in children as they get older, a shorter duration of antibiotics is very appropriate. Now, with regard to the management after a UTI, there are several recommendations that the AAP made about imaging. Some of these were similar to the original guidelines from 1999. Others changed substantially. One recommendation is that infants with a febrile UTI should have a renal and bladder ultrasound, or ARBUS for short, ideally after completing antibiotics. Findings on ARBUS that can be suggestive of vesicoureteral reflux are shown here and include distal hydroureter, hydronephrosis, and uroepithelial thickening. Additional findings may occur on the bladder component of that ultrasound study and can be impactful for that patient's diagnosis and future management, such as ureterocele or evidence of obstructive uropathy, such as posterior urethral valves with this thickened bladder and bilateral hydroureter shown here. Now to the rationale for ARBUS after the first febrile UTI. The intent is to evaluate for anatomic abnormalities that can be suggestive of conditions that have been associated with febrile UTI, such as those mentioned. However, the ARBUS has been criticized for its low yield of actionable findings, which are estimated up as low as 1 to 2%, as well as its propensity to generate false positive findings if obtained in the setting of acute infection. So dilation is not uncommon. Uroepithelial thickening is not uncommon in the setting of febrile UTI. And for this reason, it is recommended by other guidelines to obtain the ARBUS 2 to 4 weeks or 2 to 6 weeks after the UTI. The American Academy didn't define a precise time frame, but did suggest that the ultrasound could be deferred unless the patient is getting worse or there are certain atypical features of the UTI, such as acute kidney injury. It's also been stated quite accurately that if there is access to late third trimester prenatal ultrasounds, it's possible that the renal bladder ultrasound could be considered redundant. So here's a summary of some guidelines from other national organizations with regard to the utility of ultrasound for the first febrile UTI. And you can see that in the NICE guidelines recommend this in children less than 6 months, at 6 weeks after the first febrile UTI, unless certain atypical features are shown. And the Italian Society recommends the same 2 to 4 weeks after the first febrile UTI in children 2 months to 3 years. Now, this is the area in which the 1999 and the 2011 guidelines diverge significantly. The AAP recommends a selective approach to further imaging by voiding cystourethrogram, reserving this for instances in which the ultrasound is abnormal. And this, as I say, is a marked change from the 1999 guidelines that recommended all patients undergo VCUG or radionuclide cystogram. The AAP was not the first governing pediatric body to make such a change. The Italian Society of Pediatric Nephrology recommended selective approach to cystography in 2009, and the NICE guidelines in 2007 also limited the micturition cystogram to patients with evidence of renal scarring from DMSA scans. A selective imaging approach can avoid broad radiation exposure, it can reduce expense, can lower patient and caregiver anxiety, it can lower susceptibility to UTI itself on account of catheterization. The AAP's rationale for deferring VCUG until the second febrile UTI when the renal ultrasound is normal is based on a number of factors. First, in the majority of instances, children presenting with a first febrile UTI will not have a recurrence. Second, the AAP ascertained that the renal bladder ultrasound will identify abnormalities suggestive of high-grade VUR in the majority of cases, up to 80% of time based on the cited study. Third, VUR, if present, more likely will be low-grade and will resolve with time. Fourth, even if VUR is present, antibiotic prophylaxis as judged based on a meta-analysis of 6 studies in this age range is ineffective at preventing recurrent UTI in the opinion of the AAP. And finally, as stated before, the VCUG is associated with radiation exposure, expense, and catheterization, caregiver discomfort, patient discomfort. So this begs the question of what is the predictive value of renal bladder ultrasound in identifying patients with VUR, and particularly identifying patients with high-grade VUR, which we know to be associated with renal scars. Now, the guidelines do state clearly that VCUG is indicated if after the first febrile UTI, the ultrasound of the kidneys and bladder show findings suggestive of high-grade VUR, which are identified as hydronephrosis, hydroureter, evidence of renal scarring on ultrasound, knowing that ultrasound is not a sensitive test for renal scarring. Nelson and colleagues performed an analysis of over 2,200 same-day ultrasounds and VCUG studies in children under the age of 5 years and a history of UTI, of whom over 1,200 fit in the age range covered by the AAP guideline after an initial febrile UTI. And the same-day scheduling format of ultrasound and VCUG avoids verification bias, in which certain findings on one test would lead a provider to make a decision to exclude the patient from subsequent testing. These investigators used a variety of ultrasound findings to determine their ability to identify reflux or higher grade reflux. The results are shown, and you can see that the ultrasound was not particularly sensitive at identifying reflux or even identifying reflux that is dilating, with a sensitivity of 53% for identifying reflux of greater than grade 3, and a specificity that was better at 79%. So based on this study, it's hard to say that the ultrasound is a sensitive test to identify patients who have VUR, especially dilating VUR. Now, how do the guidelines from the AAP differ from other guidelines? And apologies, absolutely, that I'm not showing all guidelines, but to show examples from other countries, I'm going to show the UK and Italian guidelines. So the AAP again recommends avoiding VCUG unless a patient has a second febrile UTI, unless there's an abnormality on the ultrasound that's suggestive of reflux. The NICE guidelines from the UK recommend avoiding micturition cystourethrogram in children who are less than 6 months unless UTI are atypical or recurrent, and avoiding it also in children 6 months to 3 years, but to consider it if those findings shown are present. The Italian Society of Pediatric Nephrology recommends avoiding this test in children who are less than 3 years unless there is a non-E. coli UTI or the ultrasound is abnormal. So what's so special about non-E. coli UTIs? Well, there are a number of studies back in the 90s, as well as studies shown here, that demonstrate that a greater likelihood for patient with a febrile UTI and a non-E. coli uropathogen to have a higher likelihood of high-grade VUR, that is VUR with grades of 3 or higher. Both on univariate and multivariate analysis, Alberici found in 414 children with a first febrile UTI that the odds ratio of high-grade VUR was 2.7 with this confidence interval and significance shown. And in the RIVER study in the United States of 607 children with a history of 1 or 2 febrile UTIs and variety of grades of reflux from 1 to 4, children with a non-E. coli index UTI were more likely to have high-grade reflux, grade 4. So additional studies have attempted to identify factors that are predictive of renal scarring at the time of a first febrile UTI. That would be clinical or laboratory factors or imaging factors. And a large meta-analysis of 9 randomized clinical trials involving over 1,200 children who had a first febrile UTI identified the following risk factors. And they included the combination of a high temperature greater than or equal to 39 degrees, along with the urine culture growing non-E. coli, uropathogen, the finding of abnormal ultrasound as one would expect, the laboratory findings shown, and high-grade reflux, grade 4 or 5. This was the strongest predictor of renal scarring, but was only present in 4% of the patients. And here is a summary of those findings, and you can see with the rectangle here that compared to those who did not have reflux, that already with low-grade reflux, there is a higher odds of scarring with 1.8. The odds ratio continues to increase, and though it's far less likely to have grade 4 or 5 reflux, the likelihood of scarring in the setting of a first febrile UTI is far greater. So this kind of begs the question of which infants should undergo a late DMSA scan to detect renal scarring after a first febrile UTI. It's not recommended in the AAP guidelines. in the NICE guidelines from the UK, a late DMSA scan, that is a good 6 months after the febrile UTI, is recommended in children up to the age of 3 years with a first atypical UTI, that is a child who has sepsis, an infection with a non-E. coli uropathogen, failure to respond to antibiotics, or in infants with recurrent febrile UTIs. The Italian guidelines recommend late DMSA scan if grade 4 or 5 VUR is present, recognizing the association between high-grade dilating reflux and renal scarring. What's the impact of guidelines on imaging? It's stark, it's impressive. So here is a study of VCUG orders in a Midwest institution in the United States, and you can see how levels both in children who fall in the age range covered by the guidelines, shown here in blue, as well as older children, plummeted. They began to downtrend in association with the NICE guidelines, and they tanked after publication of the 2011 AAP guidelines. So guidelines do matter, and people do pay attention to them. Last, I'd like to address the question of prophylactic antibiotics and whether they have a role in preventing recurrent UTI. As I mentioned, the 2011 AAP guidelines recommend against prophylactic antibiotics, and they do so on the basis of a meta-analysis of data from over 1,000 infants in this age range, from 6 randomized clinical trials of antibiotics compared to placebo, and concluded on the basis of that meta-analysis that there was no benefit, regardless of reflex status or grade. The AAP guidelines acknowledge that ongoing trials are necessary and are actively readdressing this question. And they were alluding in part to the RIVER study, but also to other studies. And I'd like to spend some time talking about the findings from the RIVER study in particular, as it is a North American study, but also to mention additional studies and reviews, specifically within the 2010s, within the last decade. So again, the AAP guidelines from 2011, their meta-analysis concluded that there was no convincing evidence that prophylactic antibiotics could prevent febrile UTIs. The RIVER study that was published in 2016 with a number of subsequent papers concluded that there was a decrease in febrile or symptomatic UTI with prophylactic antibiotics. Very interestingly, a randomized controlled trial of the same antibiotic in India concluded the opposite, with an increase in febrile or symptomatic UTI in the preventative antibiotic arm of that study. And a Cochrane review of UTI in the setting of reflux in 2019 concluded there was no benefit for antibiotics in preventing pyelonephritis or renal scars. So I'd like to talk about the RIVER study, which is the randomized intervention for children with vesicoureteral reflux. Hard for me to say. The study design was a multi-center format with 19 sites, a randomized trial of antibiotic prophylaxis in the form of trimethoprim, sulfamethoxazole, compared to a placebo. The study design included children covered by the guideline, but also included children up to 5 years old at randomization. They had to have a first or second febrile or symptomatic UTI. They had to have reflux, the grade of reflux ranging from 1 to 4, and children without vesicoureteral reflux were enrolled in a parallel observational study called CUTI, possibly one of the best names of a trial for all time. The exclusion criteria are shown and included comorbid urologic anomalies and other medical conditions. So RIVER ended up enrolling 607 children, and CUTI enrolled 195 children. A number of observations were made in the course of those studies and their aftermath. The follow-up was pretty intense in the study design. Phone calls occurred every 2 months, visits to the office every 6 months for study visits. There were unscheduled visits to rule out UTI. And these patients were certainly held under a lot of scrutiny. There were DMSA scans both at the entry point to the study as well as 12 and 24 months into the study, and VCUG was performed at study entry as well as 24 months later, acknowledging the tendency for reflux in many patients to downgrade or decrease over time. The definition of UTI in the RIVER study and QD studies was as expected in accordance with the AAP guidelines, though they did use a threshold of greater than or equal to 100,000 CFUs per ml for clean voided specimen, as children with symptomatic UTI, non-febrile UTI, were included in the study. The definition of pyuria is in accordance with the AAP guidelines. In the same, it was true in fever, and the symptoms that were associated with symptomatic UTI are shown. So shown here are the Kaplan-Meier estimates, cumulative percentage of children who had afebrile UTI or symptomatic UTI according to study group. There were fewer children assigned to the trimethoprim sulfamethoxazole prophylaxis with the UTI than children assigned to placebo with a significant p-value. And in general, the tendency to have UTIs over the course of this 2-year study was around 25% ultimately in those children who received placebo, compared to around half of that in children who received antibiotics. So there's a lot of heavy debate over the significance of this finding. One conclusion is that antibiotics can reduce the tendency to have a recurrence of febrile or symptomatic UTI by 50% when given prophylactically. Another conclusion is that this is one of a statistical but not clinical significance, given the large number of patients to treat and patient years of antibiotics that would be required to prevent a single febrile UTI. Shown here, 22 patient years of antibiotics to prevent one febrile UTI. So is this an issue of statistical or clinical significance? Certainly can be debated. In terms of the tendency for prophylactic antibiotics to reduce UTI susceptibility, there's a couple noteworthy points. One is that the antibiotics were more effective in children who had an index infection that was febrile with a hazard ratio of 0.4. And the other thing that is highly worth noting, though not necessarily applied to children who are covered in the AAP guidelines, which is 2 to 24 months, but in children who are toilet trained, who have baseline bladder and bowel dysfunction, antibiotics given prophylactically could reduce this UTI recurrence substantially with a hazard ratio of 0.2. There are obviously some drawbacks to the use of prophylactic antibiotics, one being resistant, and indeed, among 87 children with a first recurrence of UTI within the study, the proportion of isolates that were resistant to the antibiotic was 63% compared to 19% in the placebo group. However, over time, the tendency of resistance actually became less significant across groups. These studies did a great deal to substantiate our knowledge of factors associated with renal scarring, as well as to identify some new ones. And this is an area that is worth emphasizing because it certainly can impact patients we see in our daily practice. It substantiated that a prolonged duration of fever prior to starting antibiotics, specifically greater than 3 days, is associated with new renal scars. That a second febrile UTI before enrollment was associated. Children with higher grade reflux had a greater likelihood of having new scars. Children with bowel and bladder dysfunction also did, as well as children with Hispanic ethnicity. I'd like to specifically highlight a couple of these in the following slides. So first of all, with regard to the number of febrile UTIs and their impact on renal scarring. In a post hoc analysis of 345 children, both in RIVER as well as in QD, the distribution shown. So you can see about 2/3 of them had reflux. Sheikh and colleagues did an analysis to look at the impact of the number of febrile UTI on scarring. And you can see here, as you would expect, that the number of patients with febrile UTI substantially decreased in the study as you go from 1 to 2. With 246 patients with 1 febrile UTI compared to 35 with 2. But the percentage of patients with scarring markedly increased. And that's shown here in this table and depicted graphically here. You know, one interpretation of this result is that the low proportion of children, you know, who have 2 febrile UTI justifies the decision to defer VCUG until the 2nd UTI. Is one interpretation. The other finding that I'm illustrating graphically here is that a delay in treatment for febrile UTI is associated with renal scarring, and specifically a greater than 3-day a lag from the onset of fever to presentation in the office is associated significantly with higher likelihood of forming new scars. And this is consistent with the last guideline in the AAP and last statements in other national guidelines in other countries. The AAP guideline states specifically the clinician should instruct families to seek prompt medical evaluation within 48 hours for future febrile illnesses to ensure that recurrent infections can be detected and promptly treated. So there's some key points from all of these studies that I'd like to leave you with. One is that the 2011 AAP guidelines are a starting point for UTI diagnosis and management, particularly from a primary care and a resource utilization perspective. The second is that this is not some sort of holy book. Like all guidelines, they do not substitute for clinical judgment, and they need to be revised and as more data emerge. And the final statement is that guidelines that apply in the United States may not be well suited in other countries, and may not be well suited in certain parts of the United States for that matter. And there is great value in ongoing dialogue and international conversations and perspectives. And perhaps we could even build towards IPNA consensus UTI guidelines. Of course, more studies are needed. We need to improve the diagnostic accuracy of the urinalysis. We need to determine if treating bowel and bladder dysfunction in children who are toilet trained reduce UTI recurrence. We need to define the role of antibiotic prophylaxis in preventing UTI in children with dilating reflux and also children with severe Kekud. And we need to better appreciate the long-term sequelae of febrile UTI and renal scarring, both in isolation or when superimposed on pre-existing chronic kidney disease, such as children with reflux and dysplasia. So with that, I'm going to stop. I hope that there are comments and questions. Thank you so much for your attention. Apologies to the many studies that I didn't highlight today. I want to salute all of the studies that I did highlight. Thank you so much for your contributions to the field. Thanks again to the organizers for the opportunity to talk. And I'll cede it from there.
Thank you very much, Brian, for this excellent overview and your wise conclusions. Thank you for that. It's really wonderful. So I think there are many, many questions, and I just may start with the first question. First question asks, can dipstick help to screen out UTI of a child with nephrotic syndrome? So what about the dipsticks for follow-up?
So the use of a dipstick to rule out for a child with glomerulonephritis?
No. So I think it's the use of dipstick for follow-up of these patients. So you have a patient with UTI, you treat him, and you may consider that this may be a high-risk patient. Do you recommend the use of dipsticks at homes for the family? So what is your approach?
We traditionally have not done that. I have. That's not something that I've done in the past because I think that you know, the concern would be the manner in which the urine is obtained, the number of false positive tests that might be generated in that setting, and also the need for the child to be assessed as well in terms of how well they are, particularly if they're febrile. I mean, I think it potentially could be done in certain circumstances, especially if the child were like very far away from the possibility to assess them, but that's not something that I would routinely do.
Mm-hmm. Thank you. Again, can you manage to look at the question, or Jane?
Yes, I think there is one concern about the application of these guidelines. You know, is starting from 2 months old. But what about those in newborn and also for those infants younger than 2 months? I think we all appreciate that the guidelines have reduced dramatically the need of invasive procedure and also radiation for these kids. But what's your comment in this group patient population that is outside the scope of the guideline? Any practice you may suggest or any evidence lately?
This is a different patient population, like you're saying, Eugene. I mean, for one thing, these patients may not necessarily have a finding of pyuria and yet have true UTIs. Another is that these patients are more prone to disseminated infection. And I think with that in mind, if there is suspicion for UTI in those patients, they may require a combination of additional diagnostic studies in the form of looking at the blood count, the differential inflammatory markers that are systemic, such as the CRP, possibly procalcitonin. There is going to be value in sending the urine for culture if you're suspecting UTI in these patients and treating them empirically. There's value from a research standpoint in devising better testing and using additional testing platforms to identify UTI, potentially NGAL in this patient population.
Thank you.
Another question is coming from Rainer Loser. He's asking any comments about UTI in the newborn?
Yeah, kind of similar, you know, and the newborn UTI is very difficult to diagnose. For one thing, I mean, we've seen tremendous heterogeneity in the diagnostics that are utilized to identify patients with UTI, you know, both here as well as elsewhere. So again, very difficult to diagnose. You need to have a kind of a strong suspicion and a low threshold to send diagnostic studies and to culture and to cover with antibiotics until there's better studies that are available.
Okay. So what about after the surgical correction of the reflux, like say for example, deflux procedure has been performed, will you routinely perform the VCUG afterwards, just to confirm the resolution of the VUR?
Yeah, it's such a partnership with urology in this case. So like I think that it's on a case-by-case basis. I think that if these procedures, deflux is not going to be as well associated with complete elimination of reflux as like a ureteral reimplantation, but these procedures have a pretty high success rate. Ureteral reimplant particularly, I don't go looking for reflux necessarily. Often what we do in those patients is make sure that they're not having any bowel or bladder dysfunction, because this is absolutely a risk factor for UTI. If they're not, take them off of their prophylactic antibiotics after their procedure and observe them closely without subsequent imaging.
Mm-hmm. And there's another interesting practical question. It's about the use of antiseptic solution in case of bagged urine sampling. So you recommend to clean the spot before the bag is taken place?
I think that this is the recommendation is to do this. Yes.
Okay.
Okay, there's one question from Professor Mahan, and Brian, would you love to comment the value of dynamic studies such as mitigating MRI in the evaluation of a child with wet bowel UTI?
John's my colleague. He's not going to like my answer to this. You know, so like I think that these studies are so something like an MRU. They are used from time to time. They can have utility, especially in identifying the ureteral anatomy. But they are not used. You know, an MRI-based study is not something that's routinely used in the initial evaluation of children with febrile UTI. There may be utility, especially in children with recurrent febrile UTI, and better identifying the anatomy or functionality.
And then another question touches the topic midstream urine collection. So when do you recommend to go for midstream collection, and what is the value? You touched this already, but it may be good to repeat this.
Yeah, I'm really glad that you asked about that. I think we probably should be doing it more often. I mean, certainly in toilet-trained children, we recommend that. That is the starting point, is to obtain a midstream collection. But you know, there are methods. The Quick-Wee method is a way to get urine from children prior to toilet training, and to get it midstream, and to do it within 5 minutes, which is faster than we can get urine from putting a bag on. And for it to be more reliable as a source of cultured urine, as opposed to a bagged urine. So I think it's something that we probably should be doing more often. That said, we don't do it, you know. So like, it requires a change in culture and a change in practice.
Okay, so here's one question for multi-drug resistance. So, will you use a quinolone group of antibiotics such as ciprofloxacin in children less than 8 years in case of multi-drug resistant UTI?
I certainly don't start with a quinolone antibiotic, but if forced to do so, we absolutely do. And we do sometimes, you know, particularly in our children with multi-drug resistant UTI, recurrent UTI, with KCUT, find ourselves in a situation where we have to prescribe quinolones. So we do.
The next is about antibiotic prophylaxis. So in case the child has an allergy against trimethoprim, sulfamethoxazole, what would you recommend as an alternative drug?
Yeah, that's a great question. Yeah, so like what we often do is nitrofurantoin. I mean, this is commonly, it's renally excreted. Potentially would not have the impact on the gut microbiome that trimethoprim would. So many of my colleagues will go with nitrofurantoin. So that would be very appropriate for prophylaxis.
Okay, there is a question about vesico-ureteric reflux, and what is your suggestion for following up the patients with a diagnosis of VUR? And what is the role of ultrasound in that case? Like, you know, sometimes they do ultrasound to like instead of a VCUG nowadays.
Yeah, absolutely. Like, you know, once the diagnosis of reflux is established, like we don't typically repeat the VCUG. And we're more prone to use ultrasound periodically to follow up, to make sure that the kidneys are growing if it's in a young child, and that there's not any new asymmetry or evidence of scarring. We would be more likely to repeat the VCUG if it's a child who has high-grade reflux, who's having recurrent febrile UTIs or breakthrough UTIs on prophylaxis, if there's been a long enough time that's lapsed, in order to assist with urology referral, and will help them with surgical decision-making.
And then there's a tricky question. It's about the value for intravesical antibiotic treatment for recurrent UTI. So is there any setting where you think there's a place for intravesical antibiotic treatment?
Yeah, definitely. Like, that's a really great question to bring up, because this touches on many of the patients who we care for. So yeah, absolutely. Like there are situations where we have patients, for example, with bladder augments who have a UTI, who may be on a catheterization regimen, or patients who are on a cath regimen who don't have an augmented bladder, but are having recurrent UTIs. And so I think if you're in a situation, say like where you have a patient who has a continent catheterizable channel such as Mitrofanoff, and they're on like every 3 to 4 hour clean intermittent catheterizations over the course of the day, I think it's very reasonable to irrigate with neomycin or gentamicin, and I see our urology colleagues do that frequently in our combined urology nephrology clinic.
Dieter, I think is almost all the questions that shown up in my chat box here.
Okay.
I'm not sure.
Yeah, no problem. There are hundreds of questions, and I'm already checking, and so many questions. So let's go. It's about the nitrite in the urine dipstick. Can it be falsely positive? Nitrite?
False positive nitrite in the urine dipstick can be falsely positive. It's like 98% specific for UTI, but I'm blanking. Possibly, I don't know. I can't think of a reason why it can be falsely positive, but I feel like there's some sage nephrologist in the group who would know the answer, wiser than me.
And then there's a very good question. It's about the hen and egg problem. So who comes first? Laura states, I think we should clearly differentiate the patients with congenital renal damage from those who have UTI, even recurrent UTI, but normal kidney.
Yeah.
So it's about it's always a question, if we see scars, is it due to UTI or it's just associated with CACUT anyway?
Yeah, I completely agree. And it is absolutely essential to differentiate these things. It's absolutely essential to define the role of acquired renal scarring in both of these entities, and ultimately the role for antibiotic prophylaxis and the impact of recurrent pyelonephritis in both of these patient populations. So I completely agree with the point. How you do that is difficult because you don't choose when you meet these patients, it's hard when these patients are not enrolled in some sort of research protocol to justify the depth of imaging that would be required to clearly differentiate, the acquired from baseline scarring in patients who already are presenting with evidence of scarring.
And then the other practical question, delay in starting antibiotics predisposed to scarring. Does that suggest in suspicious cases we start antibiotics immediately after sending for urine culture, or do we wait for a culture report?
I think that all depends on like your suspicion for UTI. I think that if you suspect that a patient has a UTI, I think that it is appropriate, particularly in patients who have recurrent febrile UTIs, patients with complicated urinary tracts who are predisposed to UTIs, to absolutely send the diagnostic studies, and it's just then on a clinical decision as to whether you start antibiotics and wait for the culture result, or take the risk of waiting and starting antibiotics once you have a positive culture.
And then there's an interesting question coming from Columbus, Ohio. You know the person. He asked, can you comment on the value of dynamic studies, for example, micturating MRI or ultrasound in order to evaluate reflux?
Yeah, I mean, I think the ultrasound is not particularly sensitive for reflux in certain studies, but it's still like the frontline screening tool that we use to identify findings suggestive of reflux in patients presenting with a first febrile UTI in accordance with the guidelines. I think that, if you get to the point where you're having 2 febrile UTI, or you're having findings such as hydronephrosis, hydroureter on your renal ultrasound, you may need to get more definitive imaging. As far as the type of imaging you obtain, you can obtain VCUG or the radionuclide cystogram. As far as MRI specifically, like if you're interested in reflux, this generally is not like the first thing that we would do. Generally, like the MRU type study is going to be used better to find like ureteral anatomy.
And then we just 2 brief questions. I think it's always about what to do with the results. So for one question is abnormal DMSA at 6 months after UTI justifies cystoretrogram if renal ultrasound is normal? Maybe you just do a statement. We have all those tools. Should we use them in clinical practice or only in studies? So how to?
It's a really great question, and I don't know the answer. Like if you have a completely normal renal ultrasound and you have that finding of scarring on your DMSA, and it looks like a focal scar, like more consistent with an acquired renal scar, I would say if it's a patient with a first febrile UTI, you could potentially justify waiting to do your VCUG. That's not consistent with some countries' guidelines. AAP doesn't have a guideline on this. Some countries would recommend going forward with the VCUG at that point to identify your high-grade reflux. But why didn't you identify evidence of that on your ultrasound? But as I just said, the ultrasound's not that sensitive. So I think you'd be in a quandary. I think if you had 2 febrile UTIs, though, then I would move forward with your VCUG.
So thank you. I'm afraid we are running out of time. That would be hundreds of questions. We tried our best. I think we asked 25 questions now, but we need to stop. But I think one conclusion is that we have to touch this topic again. So it's definitely in the program for next year. And I would like to thank Brian for this excellent presentation, and Eugen Chan for being the co-chair today, despite the technical challenges of today. And I think, Brian, do you like to announce the next webinar?
I would love to. So I'm going to be joined by Hari Pankaj, and we're going to discuss both the North American as well as the Indian guidelines and on UTI. And I'm so sorry, guys. Like I can't remember exactly when it is. Is it in March?
Yeah, we have to see. Yeah, I have to see. And please don't forget, on January 14th in the new year, the next IPNA webinar is on energy and protein requirements for children with CKD stages 2 to 5, and on dialysis clinical practice recommendations from the Pediatric Renal Nutrition Task Force, and it's presented by Vanessa Shaw. And finally, I would like to tell you that all presentations are available on the IPNA webpage, so you can have a thorough look. And I wish you all the best, and please stay healthy. Don't get sick, especially don't get sick with COVID, and hopefully we all get soon vaccination all over the world. Thank you. Bye-bye, everybody.
Bye-bye.